morning, everybody. It might be good afternoon where you are. My name is Kara Stewart Mullins. I'm the CEO of Neurobiologix. And of course, we have our guest speaker today here, Dr. Kendall Stewart. He is our Chief Medical Officer of Neurobiologix and GX Sciences. He is going to be talking about a very interesting topic today that he is very passionate about, autophagy. Just to give you a little background on Dr. Stewart, he is a neurotologist, aka skull-based surgeon, a genomic specialist, and a neuroimmune specialist. He has his own practice here in Austin, Texas, Neurosensory Center of Austin, a very busy practice. And we want to thank Fullscript for letting us have him speak today. And we'll have a Q&A at the end where you can ask him questions or send them to us via email. But to give you a little bit of background, neurotology is the practice of ENT and then extra training, of course, for skull-based surgery, which Dr. Stewart, a little bit over 9 years ago, decided to quit surgery and go on a healing path. And he has been a functional practitioner ever since in the autism world and now the everywhere world with COVID, with autoimmune, pretty much everything under the sun. But I'd like to introduce him, and I'm going to let him explain autophagy because it's a fascinating topic. And Dr. Stewart, you can take it away.
Absolutely. Thank you, Kara.
Sure.
Well, good morning to everybody, and I hope you can see my screen. But my background's also in biochemistry and cell biology. And so speaking about biochemistry, this kind of stuff gets me very excited. And basically, I'm going to take you through all the things that are exciting from my standpoint. What I'm seeing is myself. Am I everybody able to see the slides themselves?
Yes.
Okay, you're seeing the slides. Great. Okay, well, listen, autophagy is a wonderful. Let's see here, guys. Excuse me. Hang on one second. Autophagy is basically something that's involved in the healing of the cell or the potential not to heal in the cell. And so really, I like to start with a little food for thought of what we're trying to accomplish as physicians, healthcare practitioners. We're trying to accomplish health. And so I want to go back to Dr. Still, who you can see lived quite a long time ago. And his whole comments were the goal of a physician should be to find health because anyone can find disease. And I think that's very insightful because I think we've lost our way in the health department. Now, autophagy itself plays an incredible role. In healing. In fact, what we're going to talk about as far as disease states are concerned is that we have typically a triggering event, something that actually causes a massive amount of oxidative stress. That can include severe infections like COVID, like we've just experienced. It can include vaccines, environmental toxins, dietary, allergies, trauma. Emotional trauma is a big one, but what all of these type of events do is create significant oxidative inflammatory stress on the body. And that essentially will throw you down this vortex, which makes you develop a disorder. And we typically will name the disorder and try to treat the symptoms of the disorder, but what we really want to do is heal the disorder. So if we can determine the genetic predisposition of the individual patient that we are essentially treating, then we can essentially go through understanding a process where we can actually extract them from this disorder in more of a healing process instead of just covering up the disorder and allowing the disorder to continue to propagate itself. So the goal is to maximize the healing potential through creating a very favorable environment for all the structures that you're trying to heal to give them the best chance of healing themselves. Now, for me, that's the nervous system. And the nervous system is a little bit tricky because it's very, very difficult to heal. It tends to be the last thing to heal. And so when we target nervous system recovery, we want to look at not only the immune health, the methylation, the mitochondrial, the autophagy, and the detoxification status. And our genetic panels tend to do this for us. And today we're just going to talk specifically about the autophagy portion. Now, what we're going to discuss today is we're going to answer what is autophagy. We're going to answer what is the mTOR. We're going to answer what does ubiquitin do. We're going to talk about what disease states are associated with weakness in these areas. We're going to talk about how to objectively verify autophagy weakness. And we're also going to talk about treatment, which is ultimately what we're after. But if you don't understand all of this concept of the fine details of autophagy, you tend to miss the whole concept as a generalized package. And so I want to make sure that we go through a significant amount of education so you can be very versed in what autophagy really is involved with. The word autophagy actually in Latin means self-eating, and it's basically the natural regulated destructive mechanism that the cell uses to disassemble unnecessary or dysfunctional components, or what I call garbage, from the cell structure. And autophagy is basically taking this and giving it an orderly degradation and recycling these cellular components. And in fact, this is such a significant finding that this actually won the Nobel Prize in 2016 for physiology and medicine. That was given to Dr. Osumi from Japan. So this is something that a lot of doctors and healthcare practitioners do not know about. But I can tell you that once I've learned about it, once I've utilized it in therapeutics, then I can tell you that I can't heal somebody, especially in the nervous system state, without understanding and overcoming autophagy weakness. Now, the specific autophagy deficient syndromes are very numerous, and I listed a few here: diabetes type 2, inflammatory bowel disease, polycystic ovarian syndrome, Alzheimer's, dementia, Parkinson's, multiple sclerosis, amyotrophic lateral sclerosis, Huntington's chorea, benign essential tremor, macular degeneration, hearing loss, autoimmune diseases of all types, most cancers, and also autism and developmental delay. And I can prove to you by using genetics that all of these involved a significant interruption in the patient's ability to perform autophagy in their cells. So the problem with this is if you have a cell that is filling itself with garbage, and because a cell is like a small city, it's doing all kinds of things all at once. If you start to accumulate too much garbage inside of that cell, then what you have is an interruption in the functional processes of that cell. So for instance, if it's a nervous system cell, you're going to have a cell that is very challenged to create the neurotransmitters that are necessary for it to function at a normal state. Now, you can't understand autophagy without understanding the mTOR. The mTOR stands for the mechanistic, it used to be called the mammalian target of rapamycin. We actually found this mechanism, or the mTOR, which is essentially a speedometer for cellular function, by actually studying things backwards. Rapamycin is a medication that was actually developed in Toronto, and basically it was developed from an organism that was found on Easter Island in 1963. And so they kind of jacked around with this organism thinking they had an antibiotic, and in 1993 they came out with a medication called rapamycin that they thought was going to be antibiotic. But when they started using this in clinical trials, it wound up suppressing the immune system in high doses. And so nobody knew exactly how that was happening, but they wound up repackaging rapamycin and actually then selling it to the transplant doctors to suppress the immune system following kidney transplant. So what happened is Dr. Osumi began to study this because he wanted to know the mechanism of how this is working, and he actually identified a cellular structure that we now call the target of rapamycin, which is what was essentially being targeted by this drug. And so when you turn this mTOR down, basically forcing the cell speedometer to decrease its function, you are making the cell rest, and that's when the cell wants to perform autophagy. There are two distinct pathways of the mTOR. One is called the raptor, and the other is called the Richter. Now, these are distinctive pathways that are set off for different reasons. The Raptor mechanism is the one that's used in both growth, protein synthesis, ribosomal biogenesis, and many of the standard daily processes of healthy life. Whenever we get into disease states, we then go into what's called the Richter status, and this is more about proliferation and survival of cells, and this is the one that really starts to interrupt the functional capacity of cells. Now, the Raptor actually stands for Regulatory Associated Protein of the mTOR, and the Raptor itself is rapamycin sensitive, which means rapamycin will inhibit the Raptor, and when you inhibit the Raptor and make the cell rest, you will then basically cause the cell to start to clean house, and that is what autophagy is. We can also see a significant reduction in metabolism, and we also have a lot of changes in transcription. The Richter, on the other hand, which is more of the disease state, is the rapamycin insensitive complex. Now, this does not mean it does not respond to rapamycin, it's just not as sensitive as the Raptor protein, but this is the one that's associated with certain cancers, and indeed the Richter itself may be a tumor suppressor. So you're going to hear a lot about cancer and autophagy and the mTOR in the coming years, because there's all kinds of medications being developed that are typically called mTOR inhibitors. Now, you can't really understand autophagy without understanding ubiquitin. Ubiquitin is a 76 amino acid protein that basically targets a variety of proteins in the cell. What it really does is whenever you have cellular contents, you have to be able to tell inside the cell what needs to go in the garbage and what needs to stay inside the cell. So the way the cell essentially decides what to put in the garbage is that it tags the garbage with a ubiquitin molecule. And so labeling these targeted proteins basically tags them for proteasomal or autophagy-based degradation. So without ubiquitin, or if there's an interruption in ubiquitinization, then what you can have is you can have a cell that does not clean house very well and gets filled with a variety of byproducts. And in fact, what happens in most neurological diseases, whether it's Alzheimer's, Parkinsons, Lou Gehrig's, et cetera, when we look at those cells following the death of the patient, and we take a biopsy and we look under the microscope, what we essentially see is the cells are full of garbage. And in fact, the pathologist actually names the garbage inside the cell to tell you what disease it is. So when we compare that to a normal cell that is not packed full of garbage, what our whole concept was is, why do these cells have garbage and why do normal cells not have garbage, and how did this whole process occur? And that's what led to us for the understanding of autophagy and all its mechanisms. So basically, when you tag things with ubiquitin, that's this UB here, you have short-lived proteins that can be destroyed by a proteasome. You have protein stressors or aggregates. You have receptor oligization. You also have all types of oligomers that basically are involved in cellular signaling, and these will all be degraded by the autophagy process, which I'll show you in just a second. So without ubiquitin working properly, then we can't tag specific proteins and garbage for cellular degradation. Now, autophagy itself literally translates to self-eating. Its whole purpose is to clean intracellular debris that has no functional use. And there are now 4 known types of autophagy. When we first discovered it, there was only 1 known type. The major type is called macroautophagy. We'll spend quite a bit of time talking about that today. We also have microautophagy, where the material is directly transported into a liposome. We have mitautophagy, which basically is the selective degradation of damaged mitochondria. And then we have chaperone-dependent autophagy, which is newly discovered, that basically has a chaperone molecule that guides the debris into the autophagosome. So from a functional standpoint, microautophagy is very simple. If we have all of these proteins and cytoplasmic components and mitochondria that are not functioning well, we target them with ubiquitin, and when the mTOR begins to rest, what happens is you form an autophagosome, which is essentially a pocket, and because these cells are tagged with ubiquitin, they enter the autophagosome, and then the cell takes a lysosome and merges it and puts enzymes into this pocket, degrades the material back to its base structure, and then we basically recycle the amino acids and fatty acids. So essentially, without being able to clear all this cellular debris, most of our cells would then fill up with this debris and essentially lose their functional capability. Here is another type and discussion of the different types of autophagy. Macroautophagy involves the autophagosome, which is right here, that then binds and is used into the lysosomal membrane. We have macroautophagy, which essentially is a peroxisome that essentially carries it into this autophagosome. We have chaperone-mediated autophagy, where essentially a chaperone protein essentially binds a protein and then carries it or delivers it into the autophagosome. And then we have a lot of different other types of minimal autophagy that involve minor processes in the cell. But in essence, what you're trying to do is carry all of this material into an autophagosome pocket so that we can put lysosomal enzymes inside this pocket and not damage the cell to degrade all the material that is not necessarily needed within the cell. I think this is a good food for thought, especially these days, that many of us will die from science or for science without knowing it. So it's just a little food for thought to get us thinking about what we're supposed to accomplish as healthcare practitioners. Now, how do we recognize patients at risk for autophagy problems? Well, we can just wait for the disease state to happen, like diabetes or any of the major neurological diseases. I think that's an extremely poor solution. We can look at family history of disease states, and that can help us a little bit, but I still think that's a very poor solution. We can look for certain signs of autophagy defect. There are signs such as gray hair, which I have a lot of, and I do have a lot of autophagy issues, sugar cravings, blood glucose issues, hangry, visual fluctuations, many of these are very distinctive signs of somebody who struggles with autophagy. And so that can give you a slightly better understanding, but obviously the best solution would be for us to perform genetic testing on the patient. And this is nutrigenomic testing, and determine exactly the autophagy-based state of the patient that we're dealing with. So in my practice, we require our patients, in essence, for us to be able to target their therapeutics appropriately. We would like and typically require them to obtain a genetic test so that we can treat them independently and not as a single group. We want to make sure that we're targeting the specific weaknesses of a specific patient, and basically it is precision-based medicine. Now, genetic testing, if you're not very familiar with it, I'm going to go through a few things. We take a cheek swab. We then actually put it into a DNA machine where it is mixed with polymerase, and we make literally millions of copies of that genetic material. We then put it into a liquid handler that then basically breaks it down into the unique components and essentially binds it to a small chemical light diode. And then we put it into a reading machine that essentially recognizes when we have a specific gene, it recognizes the color of the diode that is chemically binded to it, and we get a data state that is put out for us. And essentially we have homozygous, heterozygous, and wild type distributions, and we read which gene is associated with which correlation on the readout graft. And that is how genetic testing typically works. Now, there are three major forms of genetic testing that you can perform. Exome sequencing is the one that's typically performed by geneticists. I think this is more of what I call doom and gloom type of genetics, because it's focused on specific disease states and genetic alterations that we really do not have a solution for. So in my mind, looking at exome sequencing, we do find genetic abnormalities in many people who have abnormal disease states. The problem is there's not anything to do about it, and everybody tends to blame that specific gene for everything that happens with the child or the patient. The second type is called pharmacogenetics, and we can look at two things. We can look at pharmacokinetics, which is the body's impact on the drug, which means how fast does the drug get broken down? Does it get broken down appropriately? Does it get broken down too slowly or too fast? We can also look at pharmacodynamics and how the drug impacts the body. And basically, this is something we do utilize in a lot of our patients, especially patients who have autism, who cannot tell us how they feel from a specific drug. So this just ensures us some degree of safety for those patients not to be either overdosed with the drug or not to use a drug that's broken down too quickly and will not give us any type of therapeutic effect. The last and most recent type is called Nutrigenomics, and this is the study of correlating gene expression and genetic differences with a drug or nutrient's absorption, metabolism, elimination, or biological effect. Now, in the panels that we've developed for GX Sciences, we must have a therapeutic option for us to consider a specific gene. Nobody wants to know that they have a specific gene without knowing that they can fix it or they can overcome it by adding a specific form of nutritional supplement. So what this is really about is being able to create the perfect environment, find the weaknesses in the patient, create the perfect environment for that patient to have the best chance to recover from whatever situation they're dealing with. And so I just went over what this is. Now, nutrigenomics is a branch of genetics that basically is done by genetic sequencing. It is the study of genetic variation or single nucleotide polymorphisms of an individual person and the biochemical effects of the nutrients absorption, delivery, metabolism, elimination, or biological action. Basically, what nutrigenomics' whole purpose is to provide an enhanced scientific and rational means to optimize nutrition and treatment options with respect to the individual's genotype. And so what that does is it basically looks at the protein coding for each specific gene that's been identified. We now know there are over 100,000 genes that have been identified. And so basically each of these polymorphisms or single changes in a base sequence is reported to a worldwide database. And basically what we then have to do is start correlating what this specific change in this single nucleotide polymorphism does to the effect of the protein sequence. And so in order for you to be reported to the database for a single nucleotide polymorphism, we have to have a variant that is present within the population of greater than 1%. So for each of these polymorphisms, when we study the population, we know exactly how common each of these polymorphisms are. And then the ones that we've listed, we are absolutely confident that the change in the genetic sequencing leads to some variation in the function of the enzyme or protein that we are dealing with. So why do we care about single nucleotide polymorphisms? Because they basically will provide appreciable differences in enzyme functions. Some SNPs can confer increased or decreased activity of a particular enzyme, and polymorphisms and their subsequent biological effects identify weaknesses in cellular biochemistry and lead to us to provide targeted treatments, lowering patient risk and decreased liability for us. So in essence, what genetics does for us is it tells us exactly what nutritional supplementation the patient needs, but just as importantly, it tells us exactly what the patient doesn't need. So the analogy that I typically use for my patients is I ask the patient if they were going to make a vegetable soup, what is the first thing that they would do? And invariably the patient says, oh, boil water, cut vegetables. The answer is actually that you'll look in the refrigerator and you'll see exactly what you have. And what that does for you is to make sure you have what components that you already own, so that when you go to the store, you only buy what you need. Because if you skip the fridge at home and go to the store, you have to buy all the vegetables, and then you come home, and when you check the fridge, you get very frustrated that you already had many of the vegetables and you wasted your money on the vegetables that you already had. So this is the same thing with nutritional supplementation. We only want to provide to the patient what they need and not necessarily what they don't need. So by using genetics, we're able to tell exactly what the patient basically processes and utilizes well, and more importantly, what they don't process and utilize well. The allele subtypes are the wild type, which essentially is a negative. This is the dominant allele in a population. We have heterozygous, where you have one single nucleotide polymorphism and a normal wild type for the other chain. We have the homozygous, which has two positives, or these are two copies of the polymorph gene. And then we have the X-linked, which essentially is the trait that's only seen on the X chromosome. And so the males have the trait conferred only by the mother. Now, this is what a classic genetic report looks like from GX Sciences. And this is the Autophagy Efficiency section, and this is a neuropsych panel. And what you can see here is we have three autophagy genes that are very important. ATG means autophagy, so we have ATG16L1, we have ATG12, we have ATG5, and you can see that this patient has each of those autophagy genes polymorphed. Now, this confers to a decreased function in the autophagy-based processes in the body, because these three genes are involved in making the autophagosome. So we then will provide the therapeutics that are associated with positive result in these patients. But we also then provide a highly recommended neurobiologics formula, because what we tend to do is we tend to compress all of these substances that are recommended into a single capsule or single therapeutic treatment. We also will have lifestyle recommendations and any other laboratories that we would recommend. We can then see here that we have the Park1 and Park2. These are Parkinson-based genes. You can see this patient does not have any significant risk, and also APOE, which is related to Alzheimer's disease. Now, I will tell you that APOE is one of the hardest genes to read and tell if there is a significant risk. There is a specific process that we have to go through with these findings in order for us to determine the relative risk of APOE. So don't just associate a positive finding here as an increased risk of Alzheimer's disease, or you will be incorrect. So let's go through some of these. This is the ATG genes. The ATG does stand for autophagy. They are hetero and homo significant, so either a hetero or single gene or double gene is significant. These genes code for the protein complex that forms the wall of the autophagosome. So remember, the autophagosome is the pocket that we put the enzymes in. So if we can't code for a normal functioning wall, then the lysosomal enzymes that are given into that autophagosome will escape and essentially damage the cell. So these are highly correlated with type 2 diabetes, with insulin resistance, with PCOS, fatty liver disease, neurological disease, autoimmune disease, hearing loss, ophthalmic disorders, and I can keep going down the list. We have the Park1 and Park2 genes. The Park1 is known as alpha-synuclein. The Park2 is known as Parkin. These are also both hetero and homo significant. The Park1 is associated with Lewy body dementia, and the Park2 is basically an autosomal recessive based process and is basically linked with early onset of Parkinsonism with slow progression. And we're going to get into the details of that in just a second. And then once again, the APOE gene, it's very important that you need 2 genes to determine the relative risk. You have to be able to read this associated SNPs appropriately in order for you to determine the relative risk. And basically this codes for an intermediate density lipoprotein, which is the principal cholesterol carrier for the brain. So if we do not have the ability to carry cholesterol to the brain, then we have an inability to make steroids in the brain, and this can create a problem with Alzheimer's, atherosclerosis, post-concussion syndrome, and macular degeneration. Diabetes type 2 is becoming a very significant problem in the patient populations in general. And I want to show you how that happens in basis to autophagy. So basically, what happens in insulin-resistant types of states is that we actually create a vicious cycle when the autophagy genes are not functioning properly. Now, many people, because of their obesity, are at higher risk. And what happens is in this obesity state, because you have this excessive calorie and fat intake, is that you never have time for the cell to rest. That continual feeding of nutrition keeps the mTOR working, and basically that keeps the autophagy in a significant decreased state, meaning that because the cell is always working, trying to provide nutritional balance, we essentially have autophagy that doesn't perform. Now, once that debris starts to build up, we will then increase the amount of insulin and lead to insulin resistance, which also then leads to protein biosynthesis. And eventually, because we are not essentially clearing the cell of all debris, the debris will start to interrupt with the protein folding and unfolding, and these bad proteins will start to accumulate. Now, once they've accumulated, then what happens is we then see a significant debris accumulation within the cell that continues to impact the folding and unfolding of proteins, and this accumulation will eventually lead to a cell that does not really respond to insulin appropriately. So what happens is this autophagy weakness, when you're early on in life, if you are using a lot of calorie intake and we cannot clear the cellular debris, as we age into our later years, we will then develop this accumulation of debris that leads to a massive risk of insulin resistance. Now, if we can interrupt the excessive calorie and fat intake, and we can help the autophagy function better, we can avoid this whole process. And that's the purpose of nutrigenomic testing. So remember, what we're doing here is we're taking the mTOR-C, we're forming the autophagosome. So if you have weaknesses in any of these 3 genes, this pocket that we're putting all this debris in is not forming very well. So that when we put lysosomal enzymes into here, we are not getting a complete degradation, and we're getting a leakage into the cell of the lysosomal enzymes. And so interrupting this process creates a debris accumulation, which is basically problematic for the cell from a functional standpoint. Now, we can help this mTOR to trigger autophagy with basically intermittent fasting and starvation. We can help it with rapamycin. We can help it with other types of medications, and I will show you there are many, many nutritional elements that can help calm the cell and lead to a much healthier mTOR status, which we'll talk about in just a second. Autophagy weaknesses also interrupt macrophage function, and this can lead to a big problem with IBS, bacterial overgrowth of the bowel, SIBO, and many other factors. What's happening is this autophagy and the autophagosome is used to by the macrophage to take in bad bacteria and we put it into an autophagosome and then use the lysosomal enzymes to destroy the bacteria. So if we have a weak form of autophagy, our macrophages have a poor ability to clear problematic bacteria from the bowel, and this can lead to SIBO and other forms of intestinal dysbiosis. Park 2 and Park 6, which are known as Parkin and Pink One, when we have a damaged mitochondria, it turns out that the mitochondria that's damaged has to be recognized in order to be put into the garbage can. And basically, what is very unique to the mitochondria themselves is that we have to coat them with 2 specific proteins in order to label them for the garbage. And I think this is just a fail-safe to make sure we don't destroy normal mitochondria. So the first one is actually called Pink One, and the second coating is called Parkin, which is coded by the Park 2 gene. And so if we do not have the ability to coat either one of these substances and identify the mitochondria that need to be cleared, what will happen is we will then get a massive amount of mitochondrial buildup of dead mitochondria in the cell of the nervous system and lead to Parkinson-like symptoms. So what happens is it is very important for us to make sure that we clear these dead mitochondria. And in fact, when you see the brain of the people who have these types of defects, what you see is a cell full of mitochondrial shells that basically are just interrupting all the functionality of the cells that need to make this high concentration of dopamine. APOE is a little bit harder to understand. We basically have good APOE and bad APOE, and this is essentially has to help us clear soluble proteins and deliver cholesterol to cells. And so if we have a good APOE and we are able to solubilize this cholesterol carrier, it leads to a very healthy brain. But if we are not able to solubilize it, it leads to an accumulation of tau proteins within the cell, and then leads to plaque formation and eventually cognitive impairment. So what you're seeing is alpha-synuclein buildup in patients with Alzheimer's. And this is because when you cannot solubilize these, it is very hard to tag them for autophagy weakness. And so understanding APOE risk is not a death sentence. It does not mean that we have, just because you have an E4 APOE does not mean that you're absolutely going to get Alzheimer's. It means we need to start early in working on assisting your brain with autophagy way before the risk of Alzheimer's occurs. This is another slide just based on the ability of the cell to utilize clearance through the autophagy mechanism. And if we are not able to use this appropriately, it leads to tau proteins, which leads to alpha-synuclein buildup and eventually into neurodegeneration. Now, the interesting thing about this is that as we get into more tau protein accumulation, we start to limit through the debris buildup the ability of glucose to be delivered, and the nervous system cells become insulin resistant in a local area. We are now starting to call this diabetes type 4, which means we do not have diabetes or insulin resistance throughout the body. We have it in specific cells inside the nervous system, which means that those cells that essentially have too much debris, even when we trigger them with insulin, there is not enough space to transport glucose effectively. Now, this is the most important part of this talk, and that's how do we, once we've recognized these problems, how do we go about treating it? Well, you've probably heard of caloric restriction and exercise, and obviously I typically recommend at least 12 to 18 hours of fasting. 12 is pretty easy for people, 18 is a little bit harder, and that will provide caloric restriction, which essentially allows the cell to not have any type of nutrition to have to process, and therefore it will go into a resting state and increase the amount of autophagy that's processed. Exercise also does a great deal at helping those cells rest. We have high-dose antioxidants, that's IV vitamin C. We have medications, we have rapamycin, we have metformin, we have spironolactone, we have azithromycin and minocycline, which basically affect the ribosomal processing, and we have growth hormones. All of these make the cells calm down, take a rest break, and spend more time cleaning. So if you have a person who has an autophagy weakness, because they clean house poorly, they have to spend a lot more time cleaning house versus somebody who has healthy autophagy. So many times in these advanced disease states, we will use these types of medicines, but if we can identify it earlier in their life cycle, and before they start to get into these disease states, we can use supplementation, which is my preferred method. Now, the supplements that are known to help autophagy very well include D-chiroinositol and myoinositol, but specifically D-chiroinositol, resveratrol, curcuminoids, catechins, which come from green tea, pipernigrum, caffeine, and lithium orotate. So each of these provides a beautiful and well-documented effect on assisting the cell to enter autophagy clearance. So basically in Neurobiologix, when I designed many of these supplements, when we do design a supplement, the packaging is the expense. And so to me, it's much better from patient compliance standpoint for us to provide 2 or 3, 4 bottles to the patient, which may have as many as 15 or 20 ingredients, rather than giving them 15 bottles with 15 ingredients. So the ones we use for autophagy weakness most commonly is one that contains D-chiroinositol. Now, inositol, also known as previously as vitamin B8, the D-chiro is a very specific form. And basically, the indications for the use of either one of these supplements are the ATG genes, either hetero or homo, or specifically hangry episodes, which means, and if you mention this to the patient, do you become hangry? Many of them will immediately respond, if not their family members. So the objective that we have here is D-chiroinositol is the insulin's second messenger. Once insulin binds the cell, D-chiro essentially sends the signal to the glucose channel to allow it to deliver glucose. So what the D-chiro does is ensure adequate delivery of glucose to the cells. You can provide myoinositol also, lithium orotate, and chromium picolinate. And so I have all of these placed in metabolic stimulator with a lower amount of D-chiro, and we have D-chiro in a higher dose in a different form. And I will use these universally in my patients who have autophagy weakness. So here's how the glucose delivery happens. Insulin binds the insulin receptor. It then triggers D-chiroinositol as the second messenger to essentially activate the GLUT4 vesicle, which then leads the GLUT4 to the membrane of the cell to activate glucose delivery. So D-chiroinositol is a very, very important functional second messenger. And so assisting people who have type 2 diabetes or insulin resistance, by placing them on D-chiroinositol, many times you can reverse that insulin resistance or significantly improve their insulin resistance. And ultimately, the cells that need the most glucose are the highest energy cells in the body. That would include the eyes and ears and nervous system, the endocrine system, like the ovaries, the thyroid, etc., and also the immune system. And so those cells are working 24/7, and they will require a continuous amount of glucose delivery. The second method that we use to treat is called Nas Enhancer. Nas actually stands for NRF2 inhibitor, autophagy, and superoxide dismutase. And so what this is involved in is providing all the secondary agents that assist with autophagy in a single package. And so what we have is the indications for this is the ATG5, 12, or 16L1, This is also indicated in the Park and APOE mutations, and the objective is to gently inhibit the mTOR to induce autophagy. So what is in Nas Enhancer is the curcuminoids, resveratrol, phosphatidylserine, sulforaphane, black pepper extract, which is piper nigrum, catechins, and also calcium pyruvate. So this combination is very effective, and it really is shocking when you add the combination instead of just using a single agent, how much more it tends to be effective when you attack it at multiple levels. The third thing is if you have autophagy weakness, IBS, leaky gut, immune dysfunction, we have created neuroimmune infection control. Now, neuroimmune infection control basically was built to put back into our body what we have actually hybridized out of our food supply. And what I mean by that is many of the hybridizations we've done for our fruits and vegetables make them much prettier on the shelf, but they've taken out very essential functions that lead to the ability for us to control bacteria in our gut, to control the microbiome, and to essentially provide us with a healthy intestinal tract. So what this has in it is elderberry, monolaurin or lauric acid, lysine, grapeseed extract, grapefruit seed extract, olive leaf extract, bee propolis, and cinnamon bark. And what this is able to do is to provide in a single capsule many of the things that we've essentially taken out of our diet, not on purpose, but because we've actually manipulated our crops and our fruits and our vegetables. And what we want to do is be able to provide that back to the gut because it has a very important functional, we have a functional need for those things. So the last food for thought is progress is man's ability to essentially complicate simplicity. And that was by Thor Heyerdahl. And that is pretty much what I have for you today. So I'd be glad to answer any questions for you on these thoughts. And I just leave you with a little picture from Austin, Texas of our Capital of Texas Bridge. And if you ever come to Austin, I'd love to have you stop by my office and discuss these things if you've got any questions for me.
Hello, everyone. So I just wanted to come in here and just thank Dr. Kendall Stewart for that amazing presentation. So we had a few questions come through and we have a bit of time left. So I will start to ask some questions. My name is Rachel. I'm from the marketing team. I forgot to introduce myself, but yeah, so I'll ask some questions to Dr. Stewart. And yeah, we'll get going here in just 1 second. Perfect. Alrighty. Okay, so someone asked, what was the first supplement that you reviewed?
The first supplement I reviewed was D-chiroinositol.
Okay. So the next question is, can a Parkinson's patient begin using these supplements?
Absolutely. In fact, you want to start using them because Parkinson's is a progressive disease. So once it starts, basically the earlier you can interrupt it, the better. So that's the whole purpose of basically nutrigenomic testing, because what you'll have is if you have a patient who has Parkinson's, it's always their kids that are worried that they're going to develop it. So many times we'll actually test the entire family. And if they have this risk of Parkinson's, we start to actually treat them nutritionally far before even the relative time that you would anticipate development of Parkinson's.
Perfect. Okay.
Next. Better to be safe than sorry.
Okay, so what is your experience with spermadine for autophagy?
I don't have any experience with that. I mean, I can tell you I know about the functional capacity for that, but I don't have any experience with it.
Okay, awesome. Next question is, are there any contraindications with blood thinning medication?
The answer is no. These are nutritional elements that are bioequivalents. So everything in the body, with the exception, especially in the D-chiroinositol and lithium orotate and things like that, there's no contraindication to use in any medications in general. Now you have to be a little careful with the Nas Enhancer, because some of those secondary agents like curcuminoids and things can modify the P450 enzymes in the liver, and sometimes there is some mild interactions, but so you just have to be a little careful with the Nas Enhancer and make sure you're not on a medicine that some of those specific high-level antioxidants are not going to interrupt.
Perfect. Okay. Next, if one is hypoglycemic, can they take DCI 500?
Yeah, so DCI does not worsen hypoglycemia. It actually stabilizes it, because what hypoglycemia involves is actually an overactive amount of insulin typically. So by taking DCI, we also see that we actually help the pancreatic islet cells regulate their insulin much better. So DCI is actually indicated for hypoglycemia and hyperglycemia. So what I would just encourage you, if you have a patient who is kind of brittle in a hypoglycemic state, to use the lower doses of DCI. So I wouldn't start with the DCI 500. I would start with the metabolic enhancer, which has only 150 milligrams of D-chiroinositol.
Okay, so next I have someone that asked if you take referrals for your clinic from across Canada, and yeah, and for the contact information.
Yeah, I've got lots of Canadian patients.
Awesome, perfect. And do you have contact information you'd like to share, or?
You can certainly get a hold. My office is called the Neurosensory Center of Austin. The phone number is 512-338-9840, and basically my practice these days is extremely complicated neurological and immunological disease states that everybody's kind of given up on, and so those are the people I love to see.
Awesome. Perfect. Next question is there a role for NAD+ in autophagy?
Okay, so the answer is absolutely. The problem with NAD+ is when you actually make it into a supplement, it loves to be oxidized very quickly. So you typically will get in a supplement that's oral NADH instead of NAD+. Now we do use IVs of NAD+ in the office, and there is no doubt that NAD increases the mitochondrial regulation and energy state, and it can improve autophagy significantly. So we use a lot of those tricks in the more advanced disease states like Alzheimer's, dementia, Lou Gehrig's, etc.
Perfect. So yeah, so then another question said, please tell more about the Alzheimer's approach.
Okay, so first of all, Alzheimer's is very frustrating. It's a lot more complicated than just what we have discussed here. From a genetic standpoint, in all the patients who have Alzheimer's, we find several weaknesses. One is we find a weakness in autophagy, which we've discussed here. The second is we find a significant weakness in what I call the off switches of the immune system. So once you turn on the microglia of the nervous system, it creates inflammation in the brain, and inflammation increases the mTOR, which makes the cells stressed. And so if you have an autophagy weakness, then those stressed cells never rest, and therefore they never go through autophagy, and we get into this vicious cycle of problems with debris accumulation. And more importantly, there are actually 2 times in your life where you actually have cells that don't rest very well. One is your teenage years. And so your teenage years, because your cells are growing like crazy, you really don't go through a lot of autophagy, and a lot of the things we kind of classify as kind of dumb teenager decisions, I think a lot of it has to do with autophagy and glucose delivery problems. So many times if you're struggling with a patient who has some ADD, ADHD, attention disorder, adding some autophagy help with D-chiroinositol will significantly help those young people. The same goes for patients over the age of about 60. I'm 57, and I can tell you for sure that your cells have to work harder than they did when you were younger. And so after the age of about 60, your cells start to work harder and work harder than they did before. That keeps the mTOR activated, and any type of autophagy weakness is magnified. And that's why we see all of these neurological old people diseases. And that's why diabetes is such more common in the elderly population. And all of these autophagy-based diseases are much more common in people of older age. So by addressing that earlier on, we essentially are able to calm the inflammation, assist the autophagy. And then what we also have is we have an ability to check genetically what we call the neurotrophic factors. The neurotrophic factors are the factors that are involved in healing and recovery of the brain and nervous system. Those include synapsin 1, brain-derived neurotrophic factor, and nerve growth factor. And so each of those specific neurotrophic factors, we check genetically to look for weakness. And if they are weak, we typically go to exosomal or stem cell therapeutics to overcome those weaknesses. So our approach to most of these advanced neurotrophic diseases includes creating the perfect environment for healing in the patient and giving them the best chance of healing themselves. And if they're not able to, we then typically come in, if they're indicated with exosome therapy, to try to assist in them overcoming the disease state.
Awesome. Perfect. Okay. Next question is, can this be used for type 1 diabetes and inositol?
Yes, it can. And in fact, it keeps you, especially in people who are having to use higher doses in type 1, you just have to be really careful with it. You know, if you use a lot of dechironinositol in a type 1, you're going to find out how powerful vitamins can be. Okay, so what I would encourage you in type 1 is you just want to be gentle in how you introduce it. Do it in a slow, methodical way and let the body kind of adjust to it.
Awesome. Okay, the next question is, are these supplements on Fullscript and will they be available in Canada?
The answer is yes.
Awesome. Perfect. Okay, next question is, how do you decide how many hours the intermittent fasting should be for a patient?
You know, there's no real great decision, and there's really not a lot of data related to that, you know. And so I basically tell patients that if you're going over 12 hours, you're definitely helping yourself. And the easiest way to do that for me is for you to eat an early dinner and basically have a late breakfast or wait till lunch. So I can tell you, for me, I typically will eat dinner between 6 and 7, and then on many days, about 4 days a week, I'll skip breakfast and we'll wait till lunch to eat, and that gets me the 12 to 18 hours.
Perfect. Okay, awesome. And next is, I have a patient with neuropathy, sorry. Would you be able to help her and work with me with the supplements?
Sure. Yeah, absolutely. Love that stuff. Now, the only thing I'll mention in neuropathy is if it's peripheral neuropathy, almost always you have a viral activation process. Typically with the herpes family, and in particular shingles is very notorious for leading to significant damage and inflammation in the nerves. So basically what will be involved is the nutritional aspect, and some way of us targeting the herpes family will almost always lead to a good outcome in neuropathy. But by checking the neurotrophic factors, you'll know whether that patient, genetically, you'll know whether that patient is capable of healing themselves. So if their neurotrophic factors are weak, then that patient usually cannot heal themselves. So that's when you have to decide whether to use exosomes in order to help them overcome the neuropathy.
Awesome. Okay, next question is, do you retest after using supplements?
No, there's no reason. Now that's a different story. You're looking at micronutrient testing. So genetics are genetics, they don't change. And so what you have is what you get. And so once you test them, what you know is the pathways that are interrupted. Now, the biggest problem in general with micronutrient testing is you're trying to figure out what's in the cell, not what's in the blood, Remember, what we're looking at is how does a nutrient get absorbed into the blood, and then how does that nutrient get transported into the cell, and then once into the cell, how does it get processed into the right form? And so there can be interruptions all along that, and there is just not a wonderful way to check intracellular micronutrients. There have been tests developed, SpectraCell's one of them, et cetera, but it's just a very difficult objective to really understand. And so with genetics, you know the base foundation of how strong the enzymes are, and it just makes it much easier for us to overcome the weaknesses that we can recognize. Now, what we will typically do, though, is we do use objective testing, tests that you can't fake neurologically, to document improvement in function. So for instance, we'll use otoacoustic emissions, which are where we listen to the hair cells of the ear. We look at acoustic reflexes. We look at things that you cannot fake, and we are able to document improvement in neurological function with the supplements that we utilize.
Alrighty. Next is, does the MTHFR2 mutation play a role in this?
Absolutely, it's a huge role. Nothing stresses a cell out more than having, it's not just the MTHFR, it's the entire pathway from folate to methylfolate. And so we look at FOLR1 and 2, we look at dihydrofolate reductase, we look at MTHFD1, we look at MTHFR, we even look at some other pathways off of that, but we're able to look at the entire pathway of methylation. Now, if you are methylfolate depleted, that creates a stress to the cell. And so you could pretty much say that methylfolate is also an autophagy modulator, because in cells, especially of the nervous system and the immune system that lack methylfolate, once you provide that, the cell becomes much more comfortable. The mTOR will rest better and impact the autophagy of the cell.
Cool, awesome. And then next question, we still have a bunch of questions coming in as well. Are you suggesting these supplements for general cellular health?
Absolutely. That's the idea. Just recognize what you need and start early.
Perfect, okay. Next is, can you expand a bit on sleep and autophagy and how to optimize?
Well, you know, sleep is one of the most complex things, and being from ENT, I've been trained in sleep disorders. The biggest issue we have with autophagy and sleep is that what most people, I think, forget is that they forget that sleep takes energy. You have to process sleep. You have to go through the different phases or stages of sleep. And that actually takes energy for the brain to process. So if you are having trouble with glucose delivery, low energy states in the cell, you are not going to be able to process the GABA, the serotonin, and all the necessary components of the necessary to initiate and process sleep properly. And so overcoming those autophagy weaknesses will invariably lead to a brain that's much more comfortable and much more elegant in its ability to sleep properly. Now, I'm not just talking about being knocked out, I'm talking about going through the specific phases of sleep to the point where you get into that deep stage sleep where you get basically the pituitary to release its growth factors, and we get all the recovery mechanisms necessary for the requirement of true quality-based sleep.
Cool. Okay. Which supplement would be appropriate for a patient with sudden hearing loss?
Okay, so sudden hearing loss, until proven otherwise, is actually shingles virus. And I can tell you that because I've biopsied a lot of nerves. That was my job. So just like the facial nerve and Bell's palsy is shingles, sudden hearing loss, most of the time, not always, but most of the time is a shingles virus. So what I will tell you is that my approach to a sudden hearing loss is, as quick as you can, you want to stop the inflammation. So if you can use some form of steroid, kind of a long-acting steroid is what I typically like to use. I like to use a Depo-Medrol injection because I like the slow, continuous release of steroid. I typically use Valtrex. If you don't have access to prescription medicines, I would use lysine and some monolaurin. And then you also want to get them on DCI as quickly as possible. Many people believe it's a vascular phenomenon. I do not believe that to save my life. In the majority of cases, we have not found that it's a vascular component causing that hearing loss. And so I typically approach it with inflammation control, antiviral therapeutics, and also autophagy modulation.
Awesome.
I also tend to modulate the inflammation using low-dose naltrexone and CBD oil in those situations too.
Perfect. Next question is, do you have many autistic kids in your practice?
I've seen somewhere between 4,000 and 4,500 autistic kids, yes, ma'am.
Okay. Which would you recommend for sickle cell patients?
Ooh. For sickle cell, I think that you can use any of these. What I would tell you is you're going to be best off using the DCI and best off using Neuroimmune infection control. You may actually have a little bit of trouble with the Nas Enhancer. I would specifically be a little cautious with the curcuminoids there. So I would really say DCI would probably be your best choice.
What effect does having complex heterozygous MTHF? Sorry, I mispronounced that.
Compound heterozygous?
Yeah. Heterozygous.
Yeah. So there are two MTHFR genes. Basically, it's the 677 and the 1298. The 1298 is a weaker, a less severe weakness in the MTHFR. So compound heterozygous means you have a single copy of a 1298 and you have a single copy of a 677. Now, the way I typically think about it, it's in the pathway of the methylation. And so a 1298 heterozygous by itself will give us a 10% weakness. A homozygous 1298 will give us a 20% weakness in that step. Compound heterozygous gives us a 40% weakness in that step. And then a single 677 will also give you a 30% weakness, but a homozygous 677 will essentially give you a 65 to 70% weakness. So compound heterozygous is somewhere between 40 and 50%. Let's just say it's not good and you need to methylate that patient.
Okay. Next is, can you use these products for P63 tumors?
Okay, P63 tumors, you can certainly use them. I would tell you you're not going to hurt anything. Typically in those types of tumors, you're going to need to get to the medications that are more beneficial. So I like to use the mTOR inhibitors in those types of tumors.
Okay, where and how is the testing done and how are the tests obtained?
Okay, so the testing is done here in Austin, Texas. The lab is actually owned by a Belgian company called Fagron, which is a multi-billion-dollar company out of Belgium. The lab specifically for the United States is in Austin. I designed the panels. What we actually do is it's a complete robotic system. And basically we take a swab of the mouth, those are sent to the lab. And then what we do is we actually run a panel of 118 genes for each patient, and we stick that in a database. Now, because we don't need all 118 genes for every patient, what I've done is I've taken those 118 and I've actually developed over 20 different symptom-specific panels. So if you have a neurological disease, you do a neuropsych panel, and that basically has about 40 of those 118. And so the patient only pays for the 40 genes at that time. Does that make sense? And so the nice thing about it is once we've tested them and we've done all 118, if you want to get another panel, you just call the company. We already have it in the database and we can immediately send it to you. So we don't run a new genetic test every time we want it for a patient. Once we've done one, we have all the genes that we need in the database ready for your access whenever you need it for the patient themselves.
Okay, awesome. Next is multiple day water fasting each month. What do you think of 4 days of water-only fasting each month?
Wow. You know, I've heard some good things about it, actually. I think that, first of all, you have to be terribly disciplined to do that type of thing. But I don't see, what I would do is make sure the patient has a severe enough autophagy weakness in order to advise for that type of process. You know, that's a hard fast.
Okay. What would you recommend for someone without diagnosis, but who wants to lose 25 pounds and is currently doing intermittent fasting, but not seeing results desired?
Yeah, so I would definitely go to D-chiroinositol in that. What I would also tell you is you probably want to check their mitochondrial function. What's happening there is Northern European people in general, and it doesn't mean it doesn't happen in everybody, but Northern European people in general, and I'm talking about people with fairer skin, fairer eyes, people of Northern European descent, we have a lot of penetrance of autophagy. Now, what's also happened in that group of people is that we have a group of genes we call thrifty genes. And so thrifty genes are really funny because more than likely Northern Europe for our ancestors was a very cold place. We went through periods of famine. And so what happens typically is that the more we try to starve ourselves, the more weight we will put on or store. And so what's really backwards in some of these people who have autophagy issues is you've got to eat enough to essentially trigger the release of the fat for the thrifty genes, but also eat little enough to trigger the autophagy bases. So adding the D-chiro will help you with the autophagy. It will also help you with the sugar modulation, but you've got to be very specific in how you arrange their diet. Does that make sense? Yeah. So we also have a dietary panel that answers a lot of those questions. GX Sciences has a diet panel that basically looks at all the different supplements that are recommended for dietary or for weight loss. And it goes through it from a genetic standpoint. So we're able to look at your genes and tell you which supplement will work for that patient.
Perfect. Is the research the same for men and women for autophagy?
The answer is yes, it is, unless it's an excellent. I mean, autophagy is autophagy. And so the only difference in women is because the ovary has such a variable function throughout the month. You know, it's really hard to be a woman from a physiologic standpoint, all the variations that you have with hormones and when you're building the endometrium. And so women with autophagy issues get into a lot more problems when they're younger versus men tend to get into a lot more problems when they're older. So you have to pay attention to young girls, even you know, preteen, from our autophagy standpoint, especially if there's a risk of PCOS or menstrual irregularity.
Okay. As a psychiatrist, pediatric and adult, could I recommend product without doing the Nutrigenomic testing?
Of course you can. That's why I told you the indications are specific. There are specific symptom indications, you know, and you can actually, once you get good at this stuff, you can actually talk to the patients and kind of know what you're probably going to see. I just like it objective because what's really nice about it, especially when you have a complex patient, to be able to show them on paper specifically what they need and show them what they don't need becomes a better value proposition for them. Okay, but there's no reason for you not to utilize these products without having genetic testing.
Do you recommend the fasting mimicking diet?
You know, the fasting mimicking, I haven't had a lot of experience with it necessarily. We do a lot of diet modification, but usually the patients I see are in pretty severe shape. It's not just a healthy population. So if you have a healthy population of patients, I think the fasting mimicking works beautifully. What it's based on is reducing the amount of insulin triggering effects. So yeah, I think it would work great. It's just much better for the healthier population.
Okay. Okay, when supporting autophagy, do you also fast from the supplements or take them at a different time?
No, you don't fast from supplements. No.
Okay. What are your thoughts on the use of TNF inhibitors for autoimmune patients, specifically rheumatoid arthritis, in conjunction with your supplemental treatment?
Okay, so basically what we're going to check in an immune panel is actually much more significant than just looking at TNF. We look at STAT4, we look at TNF, we look at CTLA4, we look at TNF receptor, we look at signal transducer and activator, we look at SCOS, we look at all types of modulators of the immune system in the immune panel. Now, if you have a TNF polymorphism, then obviously TNF blockers would work excellent. The whole idea is I can look at a patient's genetic panel and I can tell you which specific drug or process will actually help that patient based on what their genetic findings are. So I always recommend genetic testing so that I can then counsel the patient on specifically which one will work better. So if you have a patient who does not have a TNF polymorphism, there's no use in using TNF inhibitors. So if they have a STAT4 mutation, we would use a JAK-STAT inhibitor. Do you understand where I'm going with that?
Awesome. Yep. I'm going to ask another question now, moving on to the next one. What testing are you using to assess methylation?
We use a GX panel. It's called a foundation panel. It has methylation of folate, methylation of B12, and it also has all the mitochondrial SNPs. And so that's called a foundation panel.
Okay. Which of these products, if any, are good for cystic fibrosis patients?
Cystic fibrosis is tough. More than likely, you're going to get the most benefit out of the Nas Enhancer of these products for cystic fibrosis. The problem, though, is that the lungs are a high energy organ, and so you are probably going to need some DCI too, but cystic fibrosis is just a bear to deal with,
Okay. Next is any issues with medication and fasting? I believe we had a question similar to this, but it's slightly different.
The whole idea is it depends on what the medicine is. Typically with fasting, if you have what you're trying to do with fasting is you're trying to rest the body's cells so that they clean themselves. And so let's say that you're taking a blood pressure medication. I would not actually stop the blood pressure medication, because if you stop the blood pressure medication and then you create some form of hypertension, you're putting more stress back on the cells and you're losing the effect of the fast itself. So it just depends on the medications that you're specifically talking about.
Okay, awesome. And then the last question that we have time for today is, can we access the testing in Canada?
The answer is yes, I believe so, absolutely.
Okay, awesome.
I believe that they're actually going to be talking to Fullscript about getting it through you guys. Okay, Rachel?
Cool, excellent. Well, thank you so much, Dr. Stewart, for that amazing presentation. That is all the time we do have today, but if your question was unanswered, please contact Dr. Stewart at info@neurobiologix.com. So I'll wrap up this presentation by thanking you, Dr. Stewart, again for being here with us, and we appreciate all of the attendees for taking the time to join us today for the presentation. Another quick reminder is that you'll receive a copy of this recording, as well as all of the additional resources we can provide after the event, and all of the webinars are also listed on fullscript.com/webinars. So yeah, thanks again, everyone, and thank you, Dr. Stewart.
Okay, I'll see you later.
Bye.